Good morning and welcome to you all to this webinar. My name is Margot Kooijmans, Executive Director of the Philips Foundation. Philips Foundation was set up in 2014 as an official not-for-profit entity, meaning that the objective is not to make money, but to make impact. Our mission is to create access to quality healthcare for disadvantaged communities. And we want to do that where Philips is active as a company and beyond, where people need it most. With a result-driven focus, we believe that just donating money or equipment is not the best way of doing this. In our programs, we want to really understand the local context, not impose things that are created in and for other societies. We want to comprehend the cause of lack of access. What is forming the gap between people and the healthcare system? One of the key elements in this work is to utilize the community health workers, the volunteers from within the local societies, knowing their communities best. If we succeed in supporting them in a meaningful way, we have a key to supporting their communities' health and well-being when they need it. The words task shifting, task sharing, digital also, and closer to the communities are the essential concepts to make healthcare services accessible and affordable. Today, we want to share with you how collaboration with community health workers can bridge the gap between these communities and professional healthcare services. And of course, partnerships are key. Today, we have invited the Red Cross, Save the Children, our close social entrepreneurs, as well as Royal Philips, of course, to share how we do this together. Let me introduce Bahaa Eddine Sarroukh, the moderator of today. Eddine is the innovation lead of my team with a technical university background. He worked for Philips for 20 years as a scientist. He was the R&D manager and also head of Philips Research Africa. Also, Eddine is seconded to the United Nations as advisor for innovation and technology and has been working for the SDG platform in Kenya, living in Africa for several years. Eddine, please, over to you and guide us through the coming hours, please.
Thank you, Margot. Thank you for the introduction and thank you for the kind words and the real pleasure. Good morning, good afternoon, good evening to all of you. And a warm welcome again to this webinar. And it is a real honor to work with many of you and address community health as foundation for health systems to achieve universal health coverage. As Philips Foundation, we focus on addressing inequality in access to healthcare services, and we work together with our partners on the ground who can help us to reach the ones that are disadvantaged and also the ones that are very hard to reach, which is very key for our impact. Today, the world of today, we have half of the world population that lacks access to healthcare services or essential healthcare services. And also next to that, we face a shortfall of about 18 million healthcare workers, majority of them in low middle income countries. It is evident that the highest impact can be reached with community and population-based care. And community and population-based care should be able to cover most of the needs actually at the community level. And that is including, you can say, prevention, early diagnosis, treatment, rehabilitation, and even palliative care. And the impact of community and population-based healthcare goes beyond health outcomes. It includes also socioeconomic impact. So according to the WHO, the return on investment from a community healthcare worker in sub-Saharan Africa is estimated to be $10 for each dollar spent. For example, due to increased productivity from a healthier population. Ensuring immunization provides a return of $44 for each dollar spent. So ladies and gentlemen, it is not only about human rights to have access to care, but also smart from an economic growth perspective. And yet despite community healthcare workers recognize the recognized significance of their work and presence, the potential of community healthcare workers is underutilized because they are often poorly equipped, lack training, no incentive or limited incentive, no payment, limited career perspectives, all lead to keep them, or all actually can be a challenge of keeping them committed to their function. So Philips Foundation, in collaboration with partners, is exploring ways to strengthen the role of community healthcare workers by empowering them with meaningful and effective tools, technologies, skills that enable them to perform more advanced tasks or share some tasks with them. This requires, of course, inclusive design and then certainly from the right context. In various projects, we have seen that this not only helps increase community healthcare workers' effectiveness and relevance towards, you can say, better health outcomes, but can also boost motivation and even income generation, and which is the topic of today. So today we have as a topic models to strengthen access to healthcare services. We will explore this along 3 lines of discussion. We start with the basics, of course, and when it comes to design, and when it comes to design for inclusion, and it comes to developing solutions for community health, and when it means to have inclusive inclusion in it, and what does it really mean for us, and certainly as community that we would like to create the change for the community, for community-based care. So having the solution, of course, also requires an appropriate and effective implementation on the ground with the right ecosystem and the right partners, and sustainability becomes very essential. So reaching impact during implementation is the proof of the pudding, of course. And finally, of course, how do we pave the way towards sustainable and scalable impact? How do we drive towards health system change and, for example, retain the healthcare workforce? So it is my privilege to moderate the webinar of today and the panel sessions of today. So we have 3 panels with 9 great change makers in total. We will have 3 sessions. That is the way it is organized. We will have 7 minutes dialogue with each panelist in each session, including introduction, and we will wrap up with 1 closing question for each panel. So we have quite packed a session today, but also just to give you a feeling also about the great work that all these partners are doing and how we can work together towards a collective impact. So to keep indeed also the momentum and move indeed to the different sessions, I will introduce the panels. The first one, of course, and which is around inclusive design. And when we speak about inclusive design, we of course need to take it from the real context we face and the community, the disadvantaged communities that we try to innovate for them. And it is vital to understand that context. It's vital also to design to take barriers in language, health, technology, digital literacy, which we face often, of community healthcare workers or the communities where they serve. We need to take those into account. And because that is what can impact indeed the impact and the uptake and the effectiveness of the tools. And in this panel today, we have 3 design experts who will share with us their insights in barriers for adoption and strategies to solve them. They will share, of course, examples and learnings from the projects we are implementing together. And I'm ready to start with the first panelist, who is Dr. Simona Rocchi. Simona Rocchi is with Philips Experience Design. Simona manages the global creative direction of various strategic design initiatives that shape solutions for systemic health and well-being challenges. Simona has been supporting many projects of the Philips Foundation Today, we will talk about the high-risk pregnancy toolkit that was developed in close collaboration between human-centered design experts from Philips and the deep insights of the International Committee of Red Cross field workers in collaboration with the Red Cross. She also helped us develop a blended toolkit to teach volunteers to recognize the symptoms of sudden cardiac arrest and provide life-saving first aid. So allow me to welcome Dr. Simona Rocchi. Simona.
Thank you very much, Eddine. Hello, everyone. It's a pleasure for me to be in this panel.
Thank you, Simona. And I would like Simona to take this example that you have indeed supported us with and around the high-risk pregnancy referral cards, and starting with the question actually that we all certainly put in this agenda today, and we see many challenges often when we don't design for the real context, and also we don't address, let's say, inclusion. So if we talk about design for inclusion, what is it? Can you illustrate probably using actually the high-risk pregnancy card as example? And also, why is it important?
Well, indeed, let me start again, first of all, to state that design for inclusion has different meanings in relation to different challenges in different settings. In the view of the high-risk pregnancy referral card that you just mentioned, and in the context of sub-Saharan Africa to remote setting, a rural setting, to me, design for inclusion in this healthcare space mean to adopt a people-centric design approach to shape technology, solution tools that can really empower people embedded in the social fabric, like community healthcare volunteer, but even traditional birth attendants, to perform their task shifting and task sharing in a more effective way. Indeed, in context where we experience a shortage of medical expertise, is essential to leverage both the conventional and even non-conventional healthcare giver on the ground. However, like also Margot and you explained before, these community healthcare volunteers, even traditional birth attendants, often are under-equipped and not sufficiently trained. Therefore, you can imagine also a very simple tool, a paper tool, like the high-risk pregnancy referral card, can make a world of difference in their activity, in their performance. However, to truly create inclusive tools, we need tools that can be really easy of use for our target audience, and also embraced by the beneficiary. Is fundamental to understand who are the excluded ones, who are these community healthcare workers that we are talking about, what is their background, the level of knowledge, education, and their relation with technology. But equally important is really to understand the infrastructural condition and even the social cultural value, the cultural practice on the ground. This was indeed the case of the high-risk pregnancy referral tool. Was fundamental, together with the International Committee of the Red Cross, really to understand who was our primary target audience, the traditional birth attendants, to understand their level of health literacy. Indeed, with the tool, we needed to convey some medical knowledge. So we needed to understand how much they could digest this information and convey to the community once. Second, was equally important also to understand that we were dealing with fragile setting affected by war, displacement, where often there was no electricity and even no connectivity. Therefore, this is why we opt for a paper tool, not for a digital tool. And last but not least, I think for me is the most important aspect that sometimes is underestimated to design for inclusiveness. Understand really the cultural requirement. In the case of the card, originally, we created more or less a kind of standard tool, illustration, to convey the pathology, the medical risk that could lead to complication. that would be leveraged by the midwife who train the traditional birth attendants and the community as a volunteer. But we learned that in specific contexts, we needed to be very sensitive to the cultural practices. We needed, for instance, to cover naked part of the body illustrated by the card to respect the local community. And this was fundamental, not so much in the interaction between the traditional birth attendants and the pregnant woman, but in particular, when we wanted really to reach the decision maker of the care path of the woman, that often in those communities are or the husband or the mother-in-law. So it was really fundamental to design for inclusiveness in this case, to collect and digest really deep insight, deep contextual insight.
Yeah.
And I don't know if we have 1 minute left.
We have 1 minute left, and I still have actually quite a number of questions. But
okay, please go ahead.
A follow-up question to it, indeed, in less than a minute. Actually, if you would indeed give some guidance on how to design for inclusion, and also more towards on how to reduce health inequality.
Yeah, I think indeed it's fundamental to use a design people approach to bring the innovator, the designer into the community. They need to experience on the ground the barrier, the challenge and the needs, the requirement. But I think equally important, like it was in the case of designing the card, is really to leverage the expertise of your partners, of people working on the ground every day with this challenge. In this setting affected by war, for instance, was really essential to leverage the midwife of the RCRC that were training the community healthcare volunteer on the ground, not only to collect insight, but to create a first hypothesis that very quickly could be tested. And so we established a really iterative process to make sure that the tool is not only easy of use, but is fully embraced and accepted by the local community. So go there in the field, leverage the expertise of your partner, talk to people, and create a first hypothesis that can quickly readapt it and testing over time.
Very clear. Thank you so much. And you mentioned also, Simona, just in less than 20 seconds, you mentioned digital, and there's also paper. So can you elaborate a bit more? Why paper sometimes and not digital?
Yes, indeed. Again, infrastructural condition is key, because if there is no access to electricity and connectivity, you have also to consider, if you want to have an impact, what is the best means to have this impact. Second, you have to consider also the level of interaction of technology or your target audience. In the case of traditional birth attendants, for instance, we had all generation of people that were not so familiar, and even you have to consider that even when we're able to use the digital, sometimes the cost of data is very high. So also that has an impact, and you have to consider it, to discuss with all the stakeholders what is the best tool. And of course, the content later on can be also translated in a different vehicle, also in a digital platform.
Thank you so much. Thank you. And very insightful, and I think also very nice bridge to my next panelist. And I would like indeed to introduce in the next slide Orla Canavan. So Orla is a trained industrial designer, and she is the strategic product design lead of the 510 initiative of the Netherlands Red Cross. 510 is an ambitious initiative that aims to shape the future of humanitarian aid by converting data into understanding, so that aid workers can better prepare for and cope with disasters and crises. So 510 is supported by dozens of professional volunteers from outside the Red Cross. So today, Orla will share with us actually one element of 510, which is a digital tool to support crisis-affected people with cash-based assistance. So how to use design skills to assure equitable access to such critical aid. So Orla, welcome, and thank you for joining us.
Hello, humans. Thank you for having me, Eddine.
Thank you. And Orla, so actually following up also on actually the discussion we just had with Simona, certainly we talk about design for inclusion. So how do you design with people who may not ever have used a digital device before? And
right.
And should the solution always be digital? So just what I also asked indeed Simona, but maybe starting indeed with the design for inclusion itself. Yeah.
Okay, well, let me just start with regards to 510. So 510 comes from one of the circles of human-centered design, well known for technology, for data and digital technology. And the Red Cross comes from a context of viability of understanding like about 150 years of natural and man-made disasters. So the contexts are really broad. When we get to the top ends of the circles for human-centered design, we look at desirability. And that's where I would actually like to start with your question, Eddine, because how do you design a tool for somebody who's never used a digital tool before, and should you? Is the basic question that came in when I joined the team, because we were always designing digital tools. And we started designing the actual tool that was used in Kenya, in St. Martin, in Ukraine, in contexts that were highly digitalized and needing very specific aspects with regards to the contextualizations of vulnerability. And when we were given the opportunity to do the pilot in Kenya, obviously the context there changed dramatically. Connectivity is a key issue. Digital literacy is a key issue. Literacy is a key issue. But even when we map all of this out, the biggest problem we had was budget in order to talk to the individuals and find out what their desires were. What did they say to us they needed? I'm very cognizant that as a designer, I'm an Irish woman in Amsterdam, working remotely and across COVID when the pilot was taking place and the preparations for the pilot were taking place, that to listen to the voices of the owners of the problem is actually where you have to start, and not always where we have started. So to answer your question on should we use digital, in the context of Kenya, I would argue that if we had spent more budget and time in discussing this with the end user, the person affected, and indeed to contextualize it with what Simona was saying with regards to community health workers, the volunteers and the individuals that are assisting the communities in which they live, would they want to use a digital tool? In the context of Kenya, the answer is yes and no. Why? What we did is we co-designed with the community, with individuals who had been affected by drought. We understood what their needs were. They told us how they wanted to be helped. But when it came to the aid workers that were also assisting, they had a very different need. Their need was to actually be able to register people safely with dignity. Their need was to also be able to distribute cash safely to people affected without having any issues, using the local technology that's been recognized, like digital cash-based aid, sending an SMS and getting cash out to the local agents. There are different desires from the different end users. And what we decided to say with regards to budget is that we would help the volunteers and the aid workers help their community members that have been affected. What that meant was the digital tool that was being used, we could train in the volunteers and the aid workers how to use it, where they were normally finding to have to repeat 100 questions or 50 questions, translating it from potentially English to Kiswahili to Samburu or to Turkana, the local languages, meant that there was also inconsistency in the service that was being given to the person affected. How could we reduce that work? So what we did there is we looked at working with the aid workers to reduce their tiredness by the end of the day doing their workload. And how could that digital tool do it? By recording the voice with a local accent, with a local language, and making sure all the questions were asked to the person affected in a consistent manner, allowing the aid worker to take time to be the human to assist, but giving the consistency. No. So the answer is yes and no.
Clear. So, but in case of, let's say, there is no connectivity, so indeed, as you said, a yes and a no, and indeed the challenge. So how do you actually ensure a smooth, let's say, transition, let's say, from digital to non-digital?
Well, you start with the best practices that pre-exist. Like I said, there's 150 years of experience in the Red Cross. Volunteers are in that area. They know the area. They've already been doing these types of cash-based programs without any digital technology. Everything was paper-based. So you always ensure that you build from the paper-based solution, and then as a backup, literally a backup, the digital solution. And we see that across many different cases where people have been trained in Excel, people have been have great digital tools, and then the connectivity is gone. Even in a highly digitalized society, how do you continue? You make sure that your contingency is not digital, but actually that your main operation mode is paper, and then build across. It's a bit of a difficult situation to enter, because from a data and digital team, you would say that the digital entry point is where we should come from. But we should not be like throwing out the knowledge that has been built up by the community.
Yeah. And how easy actually then to understand the interfaces if you look at it from the user perspective?
So to be fair, the interface that we were using in Kenya was actually designed by a woman in St. Martin who told us that she'd been given a document on her phone with 100 questions and she couldn't answer them. And she literally said to us, she lifted up her Android phone and said, "Why can't you ask me one question at a time like WhatsApp? Why can't you do that?" And in Ukraine, then we tested and validated that concept. And then when we got to Kenya, we had a whole other set of problems. But what we decided to do was to use voice, to do one simple repetitive style. So the interface is very simple. It's a question where you can press an ear. There's pre-training before they use it. Not enough pre-training because there wasn't enough budget. But actually what the end user requested was, if you showed me how to do this before I had to do it, I would be okay. I would be less nervous. Right. And you just simply have one button and it's repeat design, listen, discuss with the aid worker that is there to help you, and then you can also listen to the options of the answers and then select.
Thank you.
First evidence is it's working, but we don't know because we need to test it further.
Thank you, Orla. I see I'm a bit over time, but very, very insightful, really amazing. I have many other questions, but I'll keep them for later. Thank you, Orla, and I would like to move to our next panelist in this session, who is Ayushi Singh. Ayushi is a senior program manager at ZMQ. She is responsible for designing and implementing technology-led interventions. ZMQ is a social enterprise from India, and also active in Uganda and Afghanistan that specializes in designing and implementing digital solutions to empower the community by providing timely information and connecting otherwise unreached people, of course, with life-saving services. So ZMQ developed the mHealth tools for behavior change and case management in a project with Save the Children on childhood pneumonia. That's something we will talk about a bit later. But allow me to welcome Ayushi. Ayushi.
Hello,
welcome.
Thank you, Eddine. Thank you, everyone. Thanks for having me here.
Thank you for joining us. And I would like actually to continue on the same direction and topic. So if we talk indeed about behavioral change and we talk about ZMQ, and certainly ZMQ is known for its low threshold design and also deployment of digital solutions for the underserved. So what can you tell us about your design methodology, Ayushi?
Absolutely. So when we look at the inclusive design model that we follow, generally it is a combination of behavior change communication, because for us, behavior change with the community we work with, behavior change forms the base of it, and then comes the services and connecting the last mile people with the services available. So it is basically it is a 3D design model that we follow to bridge that gap between what people already know in terms of what is the knowledge, what is the behavior practices, or skills, or what they have, right? The skills that they have, the capacity that they have, and what they need to know, what is the knowledge that we are trying to give out to them, what is the capacity, if we talk about community health workers, how their capacity can be built by providing them the right kind of tools available. So specifically talking about the model that we follow is it starts with the design. It starts with first D. I will talk about first D, which is designing with the community. It starts with mapping and profiling of all the stakeholders in the community, like we did with Project Vishwas as well. We worked with Save the Children, where we laid out a SBCC strategy, where we had all the stakeholders involved in the process. What should be the communication objectives? What should be the right kind of messages? So this was just the base of it. So after basic profiling of all the stakeholders, the environment, and the kind of health infrastructure that exists, then comes the next part, which is basically going on to the ground and having that real-time interaction with the community. So here we generally follow approaches like, which is participatory. So we follow approaches like story labs, game labs, or mobile labs, which we did with Project Vishwas as well. So we went onto the ground as we mapped with all the mapped stakeholders at the health facility level as well as at the community level. So we had community health workers, facility level workers, we had all the health officials mapped, and the community. So we had with a certain purpose to understand what are their needs, what are the needs, what is the social cultural background they're coming from. So I'll talk about the approach that we follow is these labs basically helps us in these labs are basically hands-on sessions where we share with them the existing tools and solutions that we have, just to give them an idea as to and see how they respond to it. In a group session, we generally give out these tools to help understand this, and also we generate solutions. So we try and interact with them and design solutions with them in the form of stories or games. So this was done under Project Vishwas, where we interacted with the community health workers. We gave out our existing solutions just to see how they respond to the interface and the kind of language that we're using. So and then we also did similar sessions with the community, with the caregivers, the primary audience of the project, to understand. So this entire process helps us in understanding the challenges that exist with the community, with the community health workers, or at the facility level. What are the different types of challenges that they follow, depending upon what kind of work they're involved with, and also related to the issue, the socio-cultural norms and practices that exist. The context, the environment, who all are the influencers, how they can be integrated within the communication design, and how they can be basically used, how they can be used for the case management system to influence the community in a positive way, of course. And then also to understand what is the technology acceptance and usage pattern, so that we design it accordingly, and the interface or the solution is such that that is user friendly. Once we identify all of these gaps in terms of knowledge, in terms of infrastructure, or management, overall case management system, then comes the design, then comes the digitization with the community. So this is the next step that we follow. So digitization is basically designing the solution which is culturally relevant. It talks to them, talks to the people in their own language. So the language is very important. Designing solution which is audio and visually enabled, keeping in mind that we are designing for a low literate audience, and of course it should be very user friendly with understandable graphics, more of iconic and navigation. But as Simona said, I completely resonate with what she said, that it is not just about the technology. We also need to understand, when we are doing such interactions with the community, we need to understand whether technology is going to work in that community or not. And if a technology is completely redundant for them, then taking technology out of this entire process is also is a part of inclusive design. So
I have one follow-up question, because I know we don't give you actually enough time actually to elaborate more about the great work you are doing, but given also the time we have for the session today, so just to understand a bit more about the let's say the design and deployment strategies, that they need to go hand in hand. So maybe you can just, in 30 seconds, if you can just elaborate a bit more.
Absolutely. So dissemination or deployment process is a part of the inclusive design. So when we are designing the solution, we design the implementation strategy as well. There are different modes that we follow. One is open dissemination, where we upload the solution onto a platform like Play Store. And then there are different strategies like house-to-house dissemination, where the community health workers move house to house and disseminate information and connects the last mile people with the health services. And the third kind of community dissemination, which is very important, and this is something that we religiously follow, is tapping into the local resources and the networks from within the community. We call them organized human networks, like schools or theater groups or community radio stations, recharge centers for that matter, because these we call them basically local technology providers. So we tap into these local networks and resources and use them to basically disseminate and move into the community.
Yeah, clear. Thank you so much. It's a really great topic, actually, already now, and we have still 2 great sessions to go. Allow me to invite the 3 panelists to come back to the session together, and close with one question, and I hope you can give me an answer within 40 seconds. So I know we need more, but I need to keep the time. So what is the biggest challenge, actually, that if you talk about deployment of design for inclusion? So what is the biggest challenge you have actually experienced in your approach, and what you have learned from it? 40 seconds. I'll start with Simone.
Okay. Again, in the context of the case that we described, rural area, remote setting, I would say that for me the biggest challenge is to create a very context-specific solution that can scale. Let me explain. A solution that, to be inclusive, needs to maximize the local relevance for the local community. However, at the same time, you want to replicate the solution to have the biggest impact. So you want to disseminate the solution in context with similar needs. And the way that we do usually to try to create a more kind of flexible tools, flexible solutions that are modular, that can update, be upgraded to be very easily recontextualized.
Orla.
I'm putting my 4 seconds on the clock. I don't know if you can see it.
Yes.
Yeah, the biggest challenge is to actually always make sure you start with the individual. If you want to design across context and iterate products across context, you start with the individual. And there's a risk, especially in the innovation sector and also in the digital sector, to want to always start in the digital, in the scalable, in what we see from a business terminology as scalable, very quickly, easily to replicate. And I think the biggest challenge within our teams specifically, and that's what we're actually rectifying, is to ensure that budget is allocated to starting with the individual, and not only start with the individual, but continue with the individual.
Clear. Thank you. Ayushi?
So one of the biggest challenge, especially when we are entering a new geography, is to ensure participation. It's the first step, basically, to ensure participation from marginalized and vulnerable section of that community. It can be women, it can be dolls and girls who are not attuned to participate in such interactive sessions at times when we are talking about remote areas, or they have a very restricted movement or are not able to speak much due to various socio-cultural barriers. So that's why it is very important to build that rapport with them and to create a very conducive environment using participatory approaches like story labs or interactive sessions or any kind of labs that we do, so that they can raise their voices where they do not feel like they're being asked something, but they're sharing their stories, and in the process we're able to understand their challenges and also design solutions with them.
Thank you, Ayushi. Thank you, Simona, Orla, Ayushi, for the great insights and sharing with us. And we look forward to continue our discussion in other occasions. Thank you. Now I would like to move to the next panel. And I think we are now ready to learn a bit more from deploying the solutions based on inclusive design. Our second panel will address the deployment and validation of technology solutions, how it can be integrated within the health systems, and how to drive towards impact. we selected 4 projects to share learnings and insights from different settings. And the projects show how to improve care management, uptake of healthcare services, manage timely referral, and support and support, of course, also timely risk identification. So our first panelist of this session is Rukia Wari, Her Excellency the First Lady of Marsabit County in Kenya. Rukia is let's say the executive director of Amen Kenya. She provides overall strategic leadership to Amen Kenya, a community-based organization in Marsabit, in the north of the country, one of the marginalized and hard to reach actually environment. Amen focuses on participatory approaches to empower people and take ownership of healthy and informed societies. And I do remember actually my visit to that region and joining her actually to see firsthand as to how even donkeys actually can be utilized and leveraged. So if it is actually difficult to reach people with the normal means. So very insightful and inspiring. And in our joint Save a Mother project, she explored the use of outreach kits with tools and enable community healthcare workers to diagnose and triage patients, and when necessary, also refer them to and connect them to the health facility or the health center. This was shown to strengthen, let's say, their role, and also to increase their effectiveness in achieving adherence to health promotion messages and the outreach of the health facilities. So, Rukia, welcome.
Thank you very much, Eddine, and hello, everyone. Very pleased to be here today to discuss this important session.
Thank you. Rukia, so if you can tell us a bit more about how this solution actually augmented the efforts of the community healthcare workers and the standard practice.
Thank you very much, Eddine. As you mentioned, this was in the remote part of Marsabit County, carefully selected because of the issues related to access issues. So we deployed innovation, not wanting to replicate what has been done before, especially the invention of the wheel in that setting. So we decided to utilize the Philips Community Life Center backpack, which was an outreach kit that was to enable the community health workers to deliver their tasks effectively. They utilized that to diagnose, refer with information and knowledge. They were also able to triage appropriately, and this really gave them the confidence to handle their tasks very effectively. Secondly, we also deployed motorbikes to community health assistants, also known as community health extension workers, to support the community health work and also the workers themselves in coordination, supervision, and also in case of emergency, they also responded using those motorbikes. These motorbikes also increased access, as we say, to outreach services, where these motorbikes were unable to peruse through or even get to the community. As Eddine has said, we had to quickly rethink around how else can we reach our communities who are unreachable, and that is the use of motors, the use of donkeys who are able to climb up the mountains and deliver the tasks. And of course, we have increased access to care through the same. We also utilized, this was partly part of design and solution at the same time. We designed locally translated flip charts that will enable them to understand the trainings that we've provided to them, the basic modules that we wanted them to utilize. So it was like an augmenting the already existing information that they have, and also deliver standardized message to the community. And the same was also deployed to augment that particular information sharing. Songs and poems were created. These were used during community dialogue days to deliver the same package. We were able to standardize these messages, so we were confident what the community health workers were delivering were in line with what the community health guideline requires of us to deliver in terms of community health promotion messages. We also had the opportunity to have videos to support and also further augment the same. So those are the two things that we used to execute our innovations in the community.
Thank you, Rokia, and inspiring indeed to see also the power of digital means and the different actually also even transport tools to see how they can really support the empowerment of the community healthcare workers and reach the hardest. So if you briefly also share with us some of the health outcomes that you have been experiencing so far.
Yes, thank you, Eddine. This was actually very interesting for us because we realized when you train them, we provided them with equipment. We even mobilized them in a model we call Rapid Results Initiative to actually seal the gap that we felt when the pandemic hit us. So we were able to mobilize them, provide them with the protective equipment and tools for surveillance and all the materials and trainings they require to deliver these tasks. And the outcome was immense. We were able to increase household visits. We were able to increase with referrals, of course, household visits with referrals. We were able to increase demand for services. Other people who are not even within the context that we are working with were requesting for services. There was also community acceptance. The community health workers were viewed as doctores, and they are called doctors of the community. So this and the interrelationship between the two, because we also have the aspect of community health-based information system, a tool we call the ODK application tool that was also supporting the community health workers deliver their reports through to the CHWs, and of course finally to the district health information system. We were able to also realize through that increased reporting, increased data quality. We formed a technical working group to also monitor through all these processes and the linkages between all this. We were able to visualize the improved reporting at the DHIS level, and it also generated some interesting information. The trends in reporting generated some very clear needs in the community that required urgent attention from the county health management team. So we were happy with the outcome from the community health workers' efforts.
Thank you, Rokia, and really pleased to have this collaboration. Let me move to my next panelist. Who is Sarah Kedenge. And Sarah is a senior scientist at Philips Research and has over 14 years experience in public health systems, strengthening, and also operational research. She's based out of Nairobi, so part of the Philips Research Kenya team, and leads the maternal and child health cluster. Sarah will talk today about actually referring back to what Simona has shared with us, the implementation of high-risk pregnancy cards toolkit, which was indeed explained, and it was tested in a project with the Kenya Red Cross in 4 counties with a reach of 250,000 people. Sarah, welcome.
Thank you very much, Eddine, and I'm really appreciative to be part of the panel on this. And I think it's very nice to see the results coming from what Simona explained with the card. So
let me
explain. Yeah.
And which is actually indeed tell us about actually how you validated the cards so that we can go towards indeed the learnings and what were the results.
Yeah, so building on what Simona mentioned, so at the point of design of the card, the ICRC opted to deploy the cards in some of the geographies that they were working, and has been highlighted earlier, considering that those were pretty much fragile settings. Having seen the promising results from that project, it was thought that if we deploy these cards in a more stable environment, would we be able to replicate or even further enhance the cards use and see much bigger results? So with that in mind, we developed a proposal, as you mentioned, with the Kenya Red Cross and also in conjunction with the ICRC to deploy the cards in 4 counties in Kenya. And we selected these 4 counties based on variation in context. The cards were designed, as Simona highlighted, to cater to different sociocultural backgrounds. So we had the cards deployed in Bomet, in Siaya towards the west of Kenya, Isiolo, which is more centrally placed, and Lamu at the coast. And you can tell the variation in the cultures across those places. So the aim of this project was then to see how do you assess the effectiveness of the use of these cards in identifying at-risk pregnancies, enhancing referrals from the community to the skilled healthcare level, and promoting healthy pregnancy habits at that community and primary healthcare level who are considered the first line. So we wanted to see if you provide this simple, not too expensive solution to these cadres who are closest to the community, would we then see any changes in knowledge, health-seeking behavior, and practice, and then see some improvements in these maternal and child health indicators, for which even Kenya is still trying to catch up with some of the global targets? So to deploy the cards, we focused on 4 key target groups. So first, we looked at the community health volunteers, and we do know with the push to achieve universal health coverage, there's been the drive to enhance their role in health promotion and health prevention activities. The second group was the health workers at the primary healthcare facility, who we know are the first line of skilled care and the link to the broader health system. And then we also had the traditional birth attendants, who are considered trusted companions to the mothers in the community. And of course, there's been the push for them to be converted from delivering at home, but also being those ambassadors to ensure these mothers get a skilled delivery. And of course, our very important stakeholder in this was the mothers, to ensure that they get the right information and then continue with the right practice. So as part of the project, we had an implementation focus, but also embedded a research piece to be able to scientifically answer, if you provide these cards, do they make a change? Yes or no? So you also asked me about the results, and we are currently analyzing the data from this project, but the results are really promising. So one thing we've seen is a significant change in knowledge, because we did interviews with over 6,000 mothers in control and intervention sites, so seeing differences between these. So a significant change in knowledge that has resulted in some changes in health-seeking behavior. So you're seeing that within the target group, so those who are providing the services and those who are actually receiving the messaging. So the community health volunteer is saying, wow, I didn't know about this before. This is really important. I'm encouraging the mothers in my households to do the following. The TBA is saying, some of these mothers, I won't dare try a home delivery. I'm escorting them to the facility. And even the mothers themselves, we saw an initiative in Bomet where they actually started working on their kitchen gardens to ensure that they have better nutrition in pregnancy. The second result we've seen is an increase in antenatal care utilization, with a reported enhanced link between the community health volunteers and the health workers at the primary healthcare level. So you're seeing a shift in the number of referrals coming from the community to this skilled care. And also they're reporting that they have a better feedback loop to ensure that they are able to follow up these mothers who have completed their referrals at the facility. Interestingly, we didn't have this as part of the project, but some initiatives sprung up through use of the cards. So we saw examples of where the cards started being used in forums such as mother-to-mother support groups, as well as male sensitization forums. So where you're getting information like the men are like, I need to know what this means. If my wife needs to eat the following, what then happens? Yeah. So those are some of the results we've seen so far on the project.
Thank you, Sarah. And if you look to the role of the community healthcare workers, so how did the tools enrich their role and within, let's say, within the health system? So how it was integrated and how it was actually enriching their role?
So I would say there are about 4 main things that enrich their role. From the beginning, there was that full end-to-end engagement to ensure that the community health worker is part of the project from the beginning. So we had the stakeholder engagement all the way from the national to the grassroots level, and the CHWs themselves. So having to help them understand, this is what we're aiming to achieve. This is what we see as the benefit of you having these cards. And then also utilizing the cards in a language that is comfortable for them. So as Simon highlighted, the cards were done to understand, and I think Ayushi mentioned it as well. So the cards had 2 languages. So currently the cards were in English and Swahili, but during the trainings, we made sure that we asked what is the term in the local language, and that made sure you have uniformity in messaging across the board. So no CHV felt left out, because we do know the cadre of CHVs that we have within our setting is very wide and very varied. And then by them being considered closest and trusted by the mothers, they felt empowered to do their job. And we also ensured that we embedded the implementation of the cards in the already existing structures. So be it their community health units linked to a specific facility, their community health extension workers were their direct supervisors, so they were all involved, and then embedded this into their routine activities, so their dialogue days, their action days, using the forms that they're familiar with. And all these things came together in ensuring, one, success of the project, continuity, but also a CHV who feels I'm able to do this with this simple tool, and I'm seeing the results that are needed.
Very clear link also actually with the design for inclusion and also how the context is important indeed for the deployments. Thank you so much, Sarah. And allow me to move to my next panelist, and I'll ask you a closing question when we have all the panelists back together. So our next panelist is Dr. O.P. Singh, and Dr. O.P. is the head of health and nutrition program implementation at Save the Children in India. He holds a PhD in health management and has long experience in research and management of health programs in India. He worked with many organizations, including USAID, BMGF, SIDA, WHO, and UN-funded projects, always in close coordination with the national and the regional or state health systems. So today, Dr. O.P. will share with us about our collaboration in Vishwash project, where we use the kind of mobile digital health tools that Ayushi has presented earlier to support health workers, including community healthcare workers, ASHA workers, so to improve awareness, prevention, care seeking, and also care management practices of childhood pneumonia. So, Dr. O.P., welcome.
Thank you so much, Eddine. I am excited to be here. And frankly speaking, I will be responding on behalf of my community health workers, the ASHAs.
Most welcome. Thank you. So, in Dr. O.P., so if we refer in the Vishwash project, so what is your experience with the tool so far?
I think under the project Vishwas, we have been piloting this tool in the urban and in rural areas, and with almost 144 ASHAs. So ASHAs are generally accredited social health activists, volunteers, who are community health workers under the National Health Mission, Government of India. So overall, till now, we have got an incremental experience of working with ASHAs. And why I'm saying incremental? Due to first, of course, reason is that ASHAs are getting digitally empowered to use mobile phones. So till now, there has been kind of a challenge with ASHAs to use this kind of technology, but this is giving them a new phase to use them. Second, moving ahead from being digitally empowered, how this digitally empoweredness is helping ASHAs to deliver their work on ground level. That is good to see, at least. So I was having a couple of interactions with the field level ASHAs, and what I learned from that, ASHAs, earlier they were not having smartphones, but with seeing the other ASHAs using this for their program implementation, they got motivated, and now they have bought new phones to use this mobile application. Even though they do not know how to use it, they are taking help of their peers or their family members to use it. So that's a great insight to see they are taking it up a level. Now, actually, what it is doing with them is that they are feeling a value addition with this whole mHealth tool that they have. Value addition in the terms of they have now improved skill of counseling during their home visits. They are able to strategize their counseling with the individual mothers or caregivers or with the groups also. That is the one of the parameters they are finding. Second, very important aspect, they are seeing that earlier they were getting diffused in terms of identifying, classifying all those pneumonia cases. But with a standard protocol available to them at one click, they are very easily able to register the cases, identify them, classify them, assess them, plus also refer them and provide appropriate counseling services. Now, this looks to be an easy process, but then, through the whole, why I called this incremental. When we started this, we had a very small bunch of ASHAs who were really willing to do it actually. But then as it's like a fire which is spread by mouth actually. So the good things spread very fast sometimes, and this is happening with the ASHAs. So now the ASHAs are saving, so they are finding it very effective for delivering the pneumonia management program within the communities. And also they are able to very correctly identify, track all the pneumonia cases at their level at this moment. So it's a kind of a boon to them at this moment, adding what I can say for the time being.
Thank you.
Yeah,
Thank you, Dr. O.P. Thank you. And we have few minutes for one more question, which is more related indeed to the impact. So I think certainly also the audience with me, we are interested to learn a bit about the impact of this work and also of the tools.
When I talk of impact, the overall aim of this tool was that how we can improve the community seeking behavior on pneumonia management and how the case management of individual cases can be improved. I'm happy to share that, the ASHAs are able to now use these mHealth tools to influence the decision making at their own level, plus also the decision making at the level of the community or the caregivers. So now they have a tool in their hand which is strategized to meet the counseling needs, actually, which is strategized to meet the referral needs, so that they are able to do it. Earlier, in the absence of ready available materials or reference materials, they were not correctly able to identify or classify the cases. Now, with a standard protocol available to them at one click, they are able to register the cases, they are able to identify, and they're able to manage them at their level. And the biggest advantage that they are getting right now is that earlier on the paper-based system, they were not able to follow up the cases, what happened to those individual cases in their areas. But now with this tool on their hand, with the kind of dashboard that they have, it is imperative that it's in their hand to take decisions and to take appropriate actions on the ground level. So this is how it's developing up step by step and moving ahead on that part. So impact-wise, it's definitely helping the ASHAs in improving their program delivery for pneumonia management.
Thank you. Thank you, Dr. Opi. Thank you. And allow me to introduce also our next panelist and try to manage the time. I know that we are a few minutes behind, but we will be good in time, so we will manage. My next panelist, last but not least, Christine Apimo. And Christine is a digital solutions specialist in the Philips Connected Primary Care Solutions venture. She has a vast experience in product development and end user training and support, as well as user experience research. One solution she has been driving in the mobile obstetric monitoring solution, which is a solution that empowers community healthcare workers to enroll and refer mothers to health facilities and subsequently make follow-up at home during home visits via mobile devices to enhance maternal care in community settings for positive outcomes. So it's a project that is used in a number of, it is an application that is used in a number of projects that we are supporting, including Aga Khan University, where we explore community-based full ANC referral chain. So allow me to welcome Christine. Christine, welcome.
Thank you, Eddine. Thanks for having me, and it's such an honor to be part of this panel.
Thank you, Christine. And Christine, maybe you can indeed share with us about the technology and how the technology increases, let's say, the value of the community healthcare workers in the health system.
Yeah, so community health volunteers, the main link between the community and the health system. So essentially their role in maternal and child health is to ensure that that mothers get to have all their ANC services on time and also adequately prepare for delivery. So we've seen a lot of digital solutions developed for community health volunteers. But just to put the MOM in context, it is a digital solution that essentially brings together the patient, the community health volunteer, and the health provider. So in this particular projects, for example, we train about 250 community health volunteers, and their role was basically to enroll mothers into the app, to make referrals to the facility, and also make follow-up visits and document this in the application. So there are many ways in which the MOM has enhanced the value of community health volunteers. And looking at maybe just to speak of timeliness, so this data that is collected at the community level by the community health volunteers is transmitted to the health facilities on a real-time basis for the healthcare workers to action. Then after that, they are able to really check the completeness of this referral, make follow-up visits on these cases, and be able to document that in the app. So this has also helped them in being involved. So they're actively involved. So we have system sending out message alerts. So these are message reminders on when their clients really need to go for their next antenatal and postnatal care visits, when they're due for delivery. So this is just for preparedness. Another key feature is the risk certification that is used by the community health volunteers, by the health providers at the facility. So the community health volunteers are really taught the different categories of risk. And once a health provider categorizes a mother in a risk category, the community health volunteer has knowledge of that, and they're also able to follow up on high risk cases, on cases that need further attention. So in essence, we see that community health volunteers are no longer bystanders, so they're actively involved through the pregnancy journey of a mother, so right from enrollment up until completion of postnatal care phase.
Thank you, Christine. And when it comes actually to the digital literacy, or let's say, so how does MOM address literacy challenges?
I think it is important to recognize the capacity of different community health volunteers, their capabilities and skills. I mean, they all come from different backgrounds. So we have CHWs who are retired teachers, CHWs who are retired health providers. So it is important to recognize this. So one thing that we did, having this in mind, is that first of all, we taught community health volunteers on basic functionalities of the phone. So how do I switch off my phone? How do I switch it on? How do I navigate through the keypad, through the applications? How do I really switch on and off my mobile data when I want to send this data to the community? So after that, we really just divided the community health volunteers in smaller groups and smaller sessions. And after gauging their understanding and capabilities, we coupled up, or rather we paired the CHW. So one CHW who is tech savvy and another one who is really still learning. And one thing that stood out is that from this peer-to-peer approach, they're very comfortable with each other, and we're really learning a lot, and we're willing to learn from each other, especially if they're community health volunteers who really did not understand fully the language in which the trainer understood. So with this approach, they're able to sit together and really teach and interact with each other from peer-to-peer perspective and in a language that they understand. And one thing that stood out is that their confidence to utilize these gadgets and to utilize the MOM solution has been improving over time.
Thank you, Christine. And does it actually, can I conclude that actually also that is how it is also driving acceptance?
Yes, I can say that is also how it is driving acceptance. But then I think it is important to look at acceptance in from different levels and different perspectives. So we have acceptance from the community, we have acceptance by the community health volunteers themselves, and then acceptance from the health providers. So we also guided the community health volunteers on how to involve the community, really being able to tell the mothers and the community at large the value of these solutions, the value of being checked on routinely, the value of taking up maternal services on time, and being that the community health volunteers themselves are from the community, then it became easy for the solution to be accepted. Another something that really stood out is the top-down approach, where we involved supervisors, we involved the Ministry of Health and partners right from the onset, just to ascertain that they have knowledge of these digital solutions and they're able to provide robust support to these community health volunteers, and also the hand-holding process, and just to ensure that they are comfortable and have owned up these solutions.
Thank you, Christine. Thank you. And with that, please allow me to invite also the other panelists to join us for one last question. So having indeed also Dr. OP, we Sarah, and we have our panelist. We have, I think, also Rukia, of course, Her Excellency. So our four panelists. We have learned actually, and quite inspiring to see the different successful projects, right? And so if we think from there, so how do we see, or how can this successful, let's say, pilots, drive towards, let's say, sustainable or scaled intervention within the health system? So how do you see that? So one question for all of you, please answer within 1 minute. So I'll start with Her Excellency Rukia.
Thank you, Eddine. I think the best approach is, most of our panelists have also talked about it, is to interact very closely with the beneficiaries who are the community, very closely by that, meaning understanding their needs and understanding their challenges is from the local context. At the same time, also there is the deliverers of the task, which is the county government of health, who are also the ones who are accountable for the health of that community. So the combination of those two things actually creates a better platform for delivery of these services, and as well looking at looking more at solutions that may not require extensive resources to deliver the task. Look at innovative solutions that are locally acceptable and also can be utilized in a longer term. And we don't need to keep on requesting for backups from organizations and other local players in the country.
Thank you. Thank you, Rukia. Sarah?
I think I agree fully with Rukia. The need for that close stakeholder engagement from the top to the bottom and vice versa, that bottom-up, top-down approach would be really key from the very beginning. It also fosters that longevity of any intervention that's there. And then utilizing the already existing structures ensures that even after the life of a project, those interventions that were there, as long as they are cost-friendly, well understood by the different stakeholders, can ensure that you can have success and embedment into the routine budgets and structures that are being utilized, say by a Ministry of Health or a community in a specific context. When you bring those things together, then you have the role of moving forward sustainably. And I think also in the first panel, there was the role of trying to look at the population and seeing, can I use digital media, for example, looking at the population and seeing whose needs can I address with the different types. So print media may be fine for one group, but also digital media may appeal to a different age group, and thereby you pass a message that results in better outcomes.
Thank you, Sarah. Dr. Opi.
Thank you, Eddine. I think I'm just echoing to Sarah and Rukia on that and adding a few steps from my side. One of the good things that we can do right now is that we can develop the digital innovation profile. So when I say by this, so if we have impact measures in place, if we have technical measures in place, if we have implementation measures in place. So when I say impact measures, what kind of changes it has made, how much user friendly it is, how much users have gained knowledge, if we can express that. In the terms of technical, if we can tell them, okay, these are fine to be, as per the protocols laid by the ministry. And on the programmatic, what are the operational solutions required to take it ahead? Another point I would like to just mention is here that with all these digital technologies in place, it would be good if we are open to adaptations or changes into it when it is contextualized for scale up and sustainability in a larger run. Plus, if we can develop an open source of networks wherein the champions or the adopters can take it ahead and they can take those information and work accordingly as per their situation. Thank you.
Thank you, Dr. Opi. Christine.
Thank you, Eddine. So I think I'd also really strongly agree with my fellow panelists that involving all these stakeholders from the onset to be able to leverage a broader array of insights, thoughts, expertise, and experience. And also one very important thing is to provide simple solutions that are easy to use, easy to understand, in a language that that the community health volunteers are comfortable to use, looking at it that they are coming from different geographical locations with different backgrounds. Thank you.
Thank you, Christine, and thank you, panelists, for joining me in this session and sharing your experiences and insights. Allow me to move to my third session and third panel. Having indeed spoken about design for inclusion and also about the deployment of the solutions, and having effective solutions based on inclusive design is, of course, important, and more so, of course, when it comes to sustainable health system strengthening. Human resource for health is one of the main challenges in the limited resource settings, as we actually started with also during the introduction. And given the high attrition rate of community healthcare workers, it is essential to gain better insight into main drivers of motivation and find ways to make that role more attractive. So the Philips Foundation supported several projects based on the hypothesis that providing community healthcare workers with tools and the tools that we have discussed today, that it can enhance their roles and will motivate them to remain in the system and keep performing their important tasks. In this panel, we have two experts who will share with us learnings from their models to retain community healthcare workers. Allow me to start with Christine Adema. So Irene Adema. My apologies, Irene. Irene is an epidemiologist and research scientist skilled in biomedical and public health and also global health research at Philips. She's based out of Kenya. She recently worked on a project with the International Federation of Red Cross and Red Crescent societies and the Kenya and Finnish Red Cross in Tana River County in Kenya, and in which they used the same outreach actually kits that Rukia has presented and spoke about earlier, but specifically looked at whether the provision of the toolkit to the community healthcare workers could be used as a motivator for retention. Irene, welcome.
Well, thank you, Eddine. It's a pleasure to partake in this exciting and timely discussions on community health.
So, Irene, how would you describe the motivation challenge for community healthcare workers, and how is it connected to attrition?
Thank you, Eddine. So maybe I'll begin with a little flavor of numbers. I like numbers. So let's say within the last 1 year, the Kenya Red Cross Society was commissioned by the government to retrain about 60,000 community volunteers, and about 28,000 new community volunteers are also introduced to the system. However, currently, if you look at those statistics and the numbers now, very few of them are still in the system, actively engaged. Most of them have dropped out of the system. And within the Kenyan system, community volunteers do not always have the necessary equipment, stipulated supplies by the government to use within the CHS in the work that they do. But access to some portable medical basic equipment and technologies, I think that could significantly advance the CHW's ability to accurately assess a patient's symptoms, correctly communicate those systems to the doctor, and to be able to maintain this effectiveness, and carry the merits of healthcare that we've achieved through the very many projects, very many interventions my fellow panelists have talked about. To be able to do this, we need regular and sustained motivation, which is required. And currently, the CHS, it's proposed that you use the $20 stipend that is given to these people. But insights from the builders who have previously done this work shows that if you use some non-financial incentives, such as just simply providing CHWs the right tools to perform their roles, this can actually quite motivate them and retain in the system. So this is what we also try to do in Philips. We really equipped a group of CHWs with some technology within our backpack in one of the studies that we did.
Thank you, Irene. And if you look to your results and actually on how the technology provision could really, let's say, contribute to the motivation compared to other incentives. So can you share some of your learnings?
Yes, it's a pleasure to do that. So first of all, we know that an empowered community health volunteer is one that is motivated and one that is with a very high probability of being retained within the health system. And technology has really proved to be one of those empowering mechanisms within the community. And there's always the assumption that CHWs do not remain in their roles because, well, they expect to have financial support. And so when they drop off from the systems, sometimes that is what is pegged to what is making them drop off. But a well-planned and financial incentive can actually provide sustained motivation. Recently demonstrated through some community projects that we did in Tana River. We aimed at exploring the use of the outreach kit as a driver for retention for CHV, equip these CHVs who are working on an ICCM project with the backpack that my colleague Rukia has alluded to. What we did was have a group of the CHVs, some of them with the backpack and some of them with another intervention that we're trying, mentoring and career. They were able to diagnose and just perform some basic triage within the community. This was still in addition to the $20 stipend provided in the project. So what we noticed is that the provision of the outreach touched on very many cross-cutting motivation and retention factors. It had a ripple effect towards very many things that motivate us CHV: training, skills, development, recognition in the community, linkage to health facilities, and it actually ranked highest among other incentives that you were actually looking and working with the community volunteers. And even one of the more interesting feedbacks from the project was that CHVs were not necessarily driven just by the money, but even having the equipment was a very big driver for them to continue being in the health system. Being able to be empowered to do their job was seen as a very, very big driver. The kit contributed to knowledge or transfer skills. So you had to do capacity building. Capacity building results in better credibility in their work because it's quite dependent on their perception in the community. Once you do that, the CHWs are an expanded role. They're able to do many more things besides just the ICCM, which is Integrated Community Case Management for Children. They're able to go into NCDs. They're actually within the health system. They feel like they're actually part of it, which is something that they really crave from the onset. And being able to do all these things, flexibility in works comes in, and as a result, you have retention and motivation being promoted within that space of community health. So those are some of the highlights you got from this project that you are doing in Tana River County. Yeah.
Thank you, Irene. But if we just take it one step further before I invite my next speaker, and then actually think more in terms of sustainability. So, what do you think actually the role of the partners, let's say, and government specifically, so to sustain this model?
An interesting question. Thank you for that. So CHV motivation as is quite complex, a subject where intrinsic motivations such as the desire to help others, the extrinsic ones such as social recognition, the prestige that come, they're quite intertwined. And finding a balance between this requires selecting an appropriate incentive that can satisfy all the expectations. So programs that quite concentrate on utilizing minimal economic incentives to CHVs, they limit their focus, ending up being very financially focused. When that drops out of the system, you find that a CHV is quite demotivated, confused, they are discontent. So moving forward, the government can adopt policies around CHV remuneration, working together with other partners. And one ideal situation, I think, would be when we are able to empower CHV to perform their duties, but also go a step further and enable that intervention to provide them to earn a living. I hope we'll be able to reach that looking forward. Yeah.
Thank you. Thank you, Irene. And allow me to introduce my final speaker, panelist of the day, who is actually a figure of retention in action. We are talking about Joost van Engen. Joost is the founder of Healthy Entrepreneurs. This social enterprise aims to provide access to basic health using solid, scalable business models, especially for vulnerable people in hard-to-reach areas. The model already empowers thousands of community healthcare workers to improve health in their communities while generating an income. So in a joint project, we piloted together with Joost a model to expand their services to include diagnostic tools and access to remote telehealth services. So through what is called doctor at distance, who can share the prognosis of test results and prescribe appropriate drugs that the community healthcare workers is then able to dispense. Welcome, Joost.
Thank you very much, Eddine. It's a pleasure to be in this great audience. Thank you so much.
Thank you, Joost. And Joost, if we look to Healthy Entrepreneurs, maybe you can explain with us actually the philosophy and how in itself it is a model of retention.
Well, thank you. The model of Healthy Entrepreneurs is actually based on supply chain, on actually empowering, exactly as Irene just referred to, community health volunteers or community health workers to give them the opportunity to actually perform what they're supposed to do, why they have been selected in their community. And we, as Healthy Entrepreneurs, believe that we can organize in a financially sustainable way a supply chain offering basic health commodities, both medical and non-medical, to be available continuously in the remote areas. So Healthy Entrepreneurs operates only in remote areas where we are able to add economic value for people who are not currently having access to commodities, which were supposed to be provided for free but are not. So what we do, we take existing community health workers, we give them an opportunity to actually make an investment, to become a community health entrepreneur. They make an investment themselves, and in exchange, they will get 5 days of training. They will get access to products provided on credit of a value of around $100 in total, and they get access to a smartphone that has 2 applications, one to provide health support and one to order products that will be delivered on a bi-weekly basis. And as Eddine says, we have started as Healthy Entrepreneurs on providing community health only, self-care and community health. But with the support of the collaboration with Philips, we have invested in a telehealth solution where we are able to expand the service deliveries on the ground, offering services in remote areas by having access to telehealth experts, nurses, doctors, who are able to actually provide prescription and treatments that are provided by our entrepreneurs again. What we achieved so far, we have more than 6,000 entrepreneurs active. who are all very much motivated because they get the capacity to operate. They generate an income, and they're actually, most important, the reason in their community to actually perform. And we will continue this journey together with Philips and probably even with Rukia in Kenya to use also the tools in the backpack to provide more diagnostic tools in combination with the supply chain, in combination with additional training. And so it's a holistic approach based on a private sector intervention in a traditionally public health intervention. But I think it's a key, it's the way forward to actually sustain and reach thousands more of community health entrepreneurs and millions of people.
Thank you, Joost. So if we refer back indeed to the technology once more, so how do you see actually the technology can further strengthen your model, especially when it comes to retention?
What we have seen over the last 5 years, growing our business in Uganda and Kenya, we have seen that we have a very high retention rate. So community health workers remain active. At the same time, like anyone, people would like to continue growing. So we have provided additional training, we have provided additional products in the basket. But where the real impact is not about another simple, nice to have product. We are talking about essential services which need to be available. So when you think about hypertension, diabetes, those are crucial diseases which, next to ICCM, as Irene referred to already, are crucial to actually respond to. And that's what we do. So we measure blood pressure, we measure blood sugar. We have groups of people who are actually taking their vitals every month, shared with a doctor at a distance, applying telehealth solutions, which are not so sophisticated because they've been used 20 years ago in Canada and Australia already. But still, I think it's very valuable to have these technology solutions available on the spot and to make sure that we are able to expand the service delivery of community health workers, giving them even more room in their community without building their capacity, because that's going to be too costly and impossible. But using the technology, the agent model being the bridge between the community members and experts at a distance who don't want to live in those remote areas anyway, making sure that we use the scarce capacity as efficient as possible.
Amazing. Allow me, Joost, actually to add Irene to our screen and ask you and Irene the following question. Maybe allow Irene to start with it. Is if we look to this model, so what does it take to bring it to a higher scale? So what we would like actually to see indeed, of course, is scale and reaching as many as we can and look indeed to interventions that we can transfer to different regions or contexts. So how do you see that, Irene?
Thank you for that, Eddine. It's true. After doing all this research you've been doing, we would really like to see how we can share it across Kenya, across the globe, in every single place where there are committed volunteers. One of the things I think that can be done is to have both partners, all government partners and the private sector and anyone else, funders and all these people come on board, so that when you're starting a project or when you're chatting out a project for committed volunteers, from the very onset, you have something within that system that is complementary. So the government can provide, yes, the incentives, but the private sector and the other funders can be able to provide more sustainable things. Something like I had mentioned the backpack before. It's one thing that produces several other outflowing motivations. So if that can be done, and then this shared out to all other counties within Kenya and within the global scene, I think if we partner in that way, we're able to bring it up to scale. Yeah.
Thank you. And Joost, so let's say we started with the shortfall of 18 million, of course, of all healthcare workers, and certainly in sub-Saharan Africa. So what does it take to scale to those many millions?
It's not an easy question. So it sounds so easy, it's not. I think Irene is completely right that there's a lot of expertise and knowledge that is actually known and we should consolidate. At the same time, as health entrepreneurs, we also very much believe in simplicity and standard operating procedures which can be replicated. So ourselves, we have an ambition to grow from 6,000 entrepreneurs today to 25,000 in the next 3 years, which is just part of our ambition, because our real ambition is by 2030 to work in at least 20 sub-Saharan African countries, mobilizing community health workers all over, reaching more than 100,000 or more. And the way to do so is actually to invest a lot in training and development, selecting the right staff, the right capacity of people who can manage those organizations, who are actually partly involved and motivated by a business by an income, but also partly by the health aspects. And at the same time, we need to groom them. We need to give them an opportunity. And so what we talk about at the moment at Healthy Entrepreneurs is about the Healthy Entrepreneurs Academy or the Healthy Entrepreneurs University, where we can take people from all those 20 countries or more, bring them in already in Uganda, where we operate at large scale, groom them, let them learn, take their experience, and actually bring it to a higher level. And at the same time, we really need to continue investing in all those straightforward tools we can offer to thousands of community health workers, that they will get the support to be motivated, both financially and non-financially, using the technology, the number of tools, to make sure the service provision can increase and actually the cost for the final consumer can remain very low. Because as healthy entrepreneurs, we believe it is about a customer. It is about serving a customer wherever the customer is, which is a very different approach from the public health approach, where we were talking about a patient we needed to cure. No, it's a customer who has a need that needs to be served, and we can use the agent model of the community health worker in the community which has been selected, has the trust to actually bring the services into the community. So there is a win-win, and I think we have designed all together with all the peers in this conversation a lot of knowledge. Please bring it together. Philips Foundation, take your lead and help us out and bring it up into our academy.
Thank you, Joost. And we are there actually to put the hands together indeed to address these challenges and work all together towards universal health coverage. Thank you all. And on behalf of all the panelists of today, I would like to thank everyone and all of you actually for joining us today in this second webinar. And on behalf of everyone, I would like to thank my panelists of today, Simona, Orla, Ayushi, Rukia, we had Sarah, we had Dr. OP, Christine, Irene, and Joost. All of you, thank you so much for participating today. It has been really an insightful webinar. With many learnings, including so the feasibility of the community healthcare workers' empowerment, task shifting, task sharing, design methods to overcome barriers and strive towards an effective community health. In our last panel, so we gained also learnings on motivation and retention and sustainable income generation through technology, enabled task extension. And we will continue sharing our learnings and the learnings with our partners, with all our audience. I expect a consolidated paper publication with the learnings from today's projects and more to come. And I really look forward to meeting you again in our next webinar. So please stay tuned with us and have a great weekend ahead. So thank you all.
Thank you, everybody. Thanks, Eddine and Margot, for facilitating this panel.